I think the message that's coming out is that preoperative anemia is now a recognized risk factor. And I think rushing into surgery and ignoring that within the next 2 years will be regarded as negligent. And I say that because the Department of Health guidelines say that you should identify and manage preoperative anemia. NICE will be saying very soon that you should do the same, and there will be sequence targets coming out next year. Or rather, the Department of Health has recommended that to NHS England for preoperative anemia. So in your specialty, cardiac surgery, where I can look up on the internet and find your individual results, as you can for mine, if you do have a problem and someone had preoperative anemia, the first question and soon will be, why didn't you manage that patient? That's a correctable risk. And that's the starting point of really my drive and my interest in this area. Controversial that may be. But you're all awake now. Can I just ask, surgeons versus anaesthetists, who are the anaesthetists here? Okay, right. Great. Few disclosures. I work for most of the companies involved in patient blood management. And you have to declare everything over $10 for the Americans, so round of coffee. So I'm going to talk very, very briefly about anemia, iron deficiency. I'm going to talk about oral iron and its role. Where does it fit in? And then go straight into intravenous iron, the background behind this. And I'm going to focus really on two debatable areas of iron therapy, allergy and infection. And I'm going to give the pros and cons of both of those, and then tell you where we're going with clinical trials in iron. We're aware of preoperative iron therapy. This is the graph that the Lancet didn't want, which basically shows that for every point decline in your hematocrit, both your morbidity and your mortality increases in non-cardiac surgery. But what about iron deficiency? We all know that you should have heme iron with vitamin C and lysine to promote absorption. It's very good for patients as well. You've got quite a lot of iron knocking around in the body. Most of it is in your red cell, and as your spleen munches up your dead red cells, that iron gets recycled. What happens in inflammation is because the export proteins are downregulated ferroportin by the protein hepcidin, that recycling doesn't happen. So although the macrophages take up and store iron as ferritin, that iron can't get out to the transferrin and can't get into the bone marrow. So EPO helps drive the early stage of red cell development, and iron is for the growth of the red cells in a simplistic manner. Ferritin is a cage. A couple of thousand molecules of iron are stored in a cage, predominantly in the liver. Macrophages also have ferritin, and bacteria attack the macrophages to get the iron out of the ferritin. And I'll come on to that later. So this is your storage molecule. Your transferrin saturation correlates with the ability to transfer that iron into the bone marrow. And the low density Haemoglobin, or the hypochromic red cells, is a real test of what's happening to the red cells themselves, and we've heard about that, and these are tests that are available in your hospital regularly. Now, what about the role of iron supplementation? Well, oral iron causes side effects. Every year, about 1 ton of elemental iron goes down with the fat burgers in the drains as patients throw them away. The side effect rate for oral iron is about 30 to 40% of all patients who take it, and it's the commonest reason that patients don't take it, and that's in the healthy population. The GI side effects are threefold higher in people on oral iron. There are new techniques coming out, and you can get liquid iron, which is fairly well tolerated. You can only buy it in Switzerland at the moment, but it will be launched in the UK soon. And there's a nanotechnology iron micro particle that will possibly be coming out, launched by the MRC in the next year or two. But what about in the hospitalized patient? So here I am, I'm going to abuse the orthopedic surgeons. So they've done some really good work. There are 9 randomized controlled trials on the role of oral iron in the hospitalized patient post-operatively, 4 of which are in orthopedics. It doesn't work in 120 patients. So anyway, the New Zealanders decided to repeat the trial. Doesn't work. Then they tried again in Sheffield. Doesn't work. And then they tried BLESS again. It still doesn't work. There are 4 randomized controlled trials on oral iron in the hospitalized patient post-operatively. It makes no difference whatsoever. There is no role for oral iron in the hospitalized patient. And the reason is because you've got active inflammation that Andy's alluded to. So what you have is you have lipopolysaccharide, or inflammation that activates hepcidin. Hepcidin shuts down the export protein. So although the iron can go into the gut, the iron can't get out the intracyte. So it doesn't matter how much iron you put into the gut, it's not going to get out. Macrophages take up any iron from the reticular endothelial cells, but they can't export it. So the ferritin levels, the circulating ferritin levels in the blood go up, but so does the stored ferritin in the liver go up. Your EPO levels are down-regulated and you get poor quality hypochromic red cells. Oral iron won't work. You have to bypass this system. And to do that, you can use intravenous iron. So intravenous iron, we don't truly know exactly how it works, but effectively you can give 1,000 milligrams, so 6 to 12 months dose of iron, in 15 minutes as an infusion. And essentially you overload the system, you directly saturate the transferrin, and you have a preferential course into the bone marrow. This was first done in heart failure patients by Stefan Anker's FHF study, where he took people according to this classification here, so functional iron deficiency, and he randomized them to receive intravenous iron or placebo. And what he showed was after 6 months, they overall felt better, their heart failure status improved, their 6-minute walk test improved, as did their EQ5D. And this was independent of any of the predefined variables, and interestingly independent of the hemoglobin. So it was an iron effect as well as a heme effect. It was slightly better in heme. So that is the first level 1 evidence in cardiac patients that intravenous iron has a role. And I'll come back to this. In surgery patients, we've heard that 1/3 of surgical patients are anemic. You can't get bedside ferritin tests, but bedside hepcidin tests. But you can get your ferritin, you can get your TSATs. True absolute iron deficiency is vanishingly rare. 3 people in 1,500 we looked at had true absolute iron deficiency. But functional iron deficiency you can identify tomorrow in about 2/3 of your patients. And if you give these people intravenous iron in observational studies, and this is work done across colon cancer and hysterectomy and lower limb using 2 different types of iron therapy, you can correct in percentages between 60 and 70% of all anemia prior to surgery in the elective setting. This is probably the largest data set available at the moment. It's not massive, but it is validated and has been reproduced in other observational studies. And the interesting thing about iron is the more anemic you are, the greater the response. So for the same dose of iron, you will achieve a higher response rate. So actually, even if you've got a hemoglobin of 70, you will still more likely to get above 10 within about 14 days as if you started at 9. And what's the background to iron? Well, this is the original Ipswich plant for Fishens, who made the first iron in the UK. But it's been around a while. It's been around since the war. A variety of different products were made. Does anyone actually know where iron is used most? No, down It's actually in pigs. So pig farmers routinely use iron because with the growth factors and the supplementation and antibiotics in pork, now that most sows are producing 10 to 15 in a litter, and there's no longer a run to the litter. So if you go to a pig farmer, they actually have their iron doses calculated for all their animals. So it's essential for growth plate formation. And that's where Pharmacosmos first built their experience. So it's extremely common in the veterinary world. The largest, digressing slightly, but the largest doping area for iron at the moment was greyhounds. But there we go. When did it really come in? It's the 1990s. In patients with renal failure, they unequivocally showed that if you give intravenous iron versus oral iron, you significantly improve the hemoglobin and the quality of life in patients with renal failure. And these data now are 20 years old. And this is where it really started, intravenous iron first started coming out. but there are potential problems. What are the causes and concerns? Well, iron is pivotal to cancer growth. HIF1 alpha, one of the main transcription factors, needs iron as a co-substrate to turn on gene function. Bacteria require iron to proliferate. It's a core substrate for any dividing cell. Also, there's concerns about allergy. And there are currently two, I think in breast cancer and adenocarcinoma of the esophagus, there are 2 trials on iron chelation as a cancer therapy in this patient group. So it's not one for everyone. And when did the iron first come out as a cause for concern? Well, this is the original data from 1932, which, although they had a fairly good result, and they described this as a success, immediately following the injection, the patient experienced a disagreeable feeling of great warmth and palpitations. So it's been recognized for quite some time that there is a problem. And why is this? Well, the iron is encased in a carbohydrate shell, and that shell used to be dextran. And so through the 1990s it was dextran. Humans have preformed antibodies to dextran. Why? Because we have dental caries. I have no idea why we have preformed antibodies, but so do the great apes. So therefore, the risk of anaphylaxis with large cell molecular weight dextran preparations is in the order of 2 to 3%. And that has been the main problem. And so when I was a junior doctor working on the renal unit, I used to carry an EpiPen in my pocket because I used to work for Ian McDougall, who did most of the trials. Where have we gone? Well, the molecules are getting smaller and we're moving away from dextran. And what you can see is that the quality of the old large iron dextrans is decreasing, and we're now down here with the latest preparations. However, there is a European Medicines Association, Medicines Agency blanket across all iron preparations saying they must be used with caution, and they must be given, intravenous iron must be given over 30 minutes, or 30 minutes of observation in the presence of resuscitation facilities. So those are the current guidelines. This is a class effect, and it was brought about several years ago due to one of the dextran components. But we've moved on. This is the evolution of iron preparations, and we're up here now with Monofert and Ferinject are really the 2 main ones that are out there. Ferric erythropoiesis was actually an MRI agent, so it was used as a contrast agent, and they noticed as a consequence of giving all this iron, patients' haemoglobin got better. It's probably going to be withdrawn because it isn't really designed for that area. So the 2 products on the market are Ferinject and Monofert. And what are these? Well, they're much, much smaller. There is no dextran. And it's a carbohydrate coat and a composite molecule which is dextran free. It's physiologically essentially normal. And the data for Ferinject is over 7,000 patients in randomized controlled trials, over 120 randomized controlled trials. And what you see is a rapid correction in hemoglobin response by 2 grams per deciliter or anemia, and also time compared to oral iron in most populations of patients looked at, whether or not it's perioperative, postoperative, etc. And looking at the side effect profile, there's very little difference compared to placebo, and it's preferential compared to oral iron, both in terms of response and also side effect profile. The other product is Monofert from Pharmacosmos. Slightly different makeup. It's a spiral of a carbohydrate with individual molecules on it. It's very comparable as a drug. They have done less clinical trial data, and they are doing more. But again, compared to oral iron, the adverse event rate in clinical trials is lower, and there doesn't appear to be any risk of anaphylaxis. With these 2 newer preparations, because they don't have dextran in them, you can get an anaphylactoid reaction, which is a complement mediated, it's called a capillary reaction, which mimics anaphylaxis. The risk is 3 per 100,000. The overall risk of death as a consequence of getting iron is 2 per million. The risk of death from blood is 8 per million. So it's safer than blood. But, as I'm supposed to be debating the pros and cons, I will offer the cons again. We know that iron is pivotal for Fenton chemistry and development of free radical reactions and development of oxidative stress. It's particularly so in the gut. And there is mounting evidence that the reason why heme iron, when you eat your beef burgers and your barbecues, it gets absorbed into the enterocyte and can't be exported. That heme iron then overloads the enterocyte and produces free radicals and may be the precursor to colorectal cancer. Certainly is the case in mice, hasn't been proven in humans, but there is a lot of animal data showing concern for iron overload in a variety of settings. So there's a lot of experimental data there. And a key pivotal paper came out in the BMJ suggesting that intravenous iron, although it's good at raising your haemoglobin and good at preventing blood transfusion, may cause infection. They showed that it's very good at increasing your haemoglobin, and this is in all patient populations. It also reduced the need for a blood transfusion by about a third. However, of the trials, and I think there are 23 trials that they looked at where infection was a secondary endpoint, so not a predefined primary endpoint, secondary endpoint, they did notice a higher risk of infection in that group. So what are the criticisms of this? Well, it's a heterogeneous group that they looked at. They looked at everything from renal to oncology to gastro, other. And although they noticed an increased risk of infection, the overall adverse event rate was not different between those that got iron and did not. So although they singled iron infection out, and there was no link to the dosage of the iron that they gave, so there was no mechanistic reasoning behind this because it didn't correlate with ferritin levels or the mechanism. What's the validity? Well, actually, they used all the different products. They used dextrose, gluconate, sucrose. Sucrose is the most heavily used safe molecule, iron carboxymaltose. And actually, there's a low risk of bias in the trials that they looked at. So you can criticize it one way or the other way, but those are the data from the meta-analysis at the moment. Against it, we did the Cochrane review, and we took the renal patients out. We showed no difference whatsoever in adverse event rates or anaphylaxis between oral iron, IV iron, or placebo. And bear in mind, the impact of anemia on sepsis is additive. And this is preoperative anemia, this is not anemia on ITU, so take trick out of this. This is preoperative anemia. And also on mortality. Here we go again. Data from a large observational study of 32,000 people with end-stage renal failure, 6,000 deaths. The more intravenous iron you receive, the more likely you are to die. That's what this trial shows. So those people who needed more intravenous iron to maintain their hemoglobin above the predefined thresholds were more likely to die. So you can read into that association many things, and this is the difference between an observational study, and my friend says, and proper randomized controlled trial evidence. Because in the FIND CKD study, where they took a 3-arm randomization in renal failure, they compared oral iron to low dose and high dose, and this trial is powered for the need for other products to increase the hemoglobin. So it's powered for hemoglobin as an endpoint, although infection was a pre-specified secondary endpoint. It's really important to know the difference between those two, because if it's a trial designed for infection, you look for infection. If it's a predefined endpoint, you will look for infection at a certain degree. But if you're just looking for adverse events rates, it's a post-hoc analysis. It's a bit like saying, well, I don't have any complications on day 2 post-surgery, but if all my patients die on day 5 and I wasn't looking for it, is that really valid? So in this trial, they showed no difference in infections between any of the 3 arms, statistically not significant for equivalence, but it's still 300 patients. and they showed no difference in adverse event rates between the groups. So against the observational data, we have level 1 evidence showing no difference, although it wasn't powered for that at the moment. I'll come back to that. Now, what about iron? Well, we've talked about hemoglobin, but don't forget, that's just hemoglobin delivers oxygen to the cells. For the oxygen to be utilized in the cells, you need to actually get your mitochondria to utilize it. This is data on quality of life in women between the ages of 20 and 50 who have iron deficiency but non-anemia, and they were randomized between intravenous iron and placebo with quality of life as an endpoint. There was a significant improvement in just about every single aspect of quality of life, either global or fatigue related. If you take the heart failure group with Stefan Anker's trial, and you take people with stable heart failure and you supplement them so they are not iron deficient with regular supplementation over a period of time, you improve their function and their quality of life, but importantly, you reduce readmission rate to hospital compared to placebo, and you reduce cardiovascular mortality. So long-term data suggests that iron supplementation in cardiac patients reduces mortality. What are the 3 upcoming trials? Last minute. The pivotal trial is taking people on hemodialysis and randomizing them to a large dose of intravenous iron supplementation versus a low dose, and it is following them up for 2 years. The outcome is infection and mortality. So the issue with infection and intravenous iron will be addressed in this trial. The Ironman study, which we're doing in Australia, and I particularly like our recruitment graph, very proud of that. We are giving intravenous iron on intensive care for the management of anemia, and we are using a bioassay to look at staphylococcal and streptococcal growth in the serum as samples 2 days after iron is given. And also our trial, which is the use of preoperative intravenous iron to treat anemia, and this is in major surgery. And this is our group doing the Dubai Ironman. So if you want to work for us, that's our colorectal surgeon, and that's our GI surgeon and my wife. You have to do an Ironman as an entry criteria. Thank you very much.